All right. Well, good afternoon, everyone. Just glad to have you in. It's Friday, so we're doing it in field for having our Friday webinars where we try to educate and advocate on things that are super important to us in the world of health equity. If you got to attend or listen to last week's webinar, we talked about Vote ER. So I'm out here and getting out the vote and make sure you go ahead and vote before Tuesday. So that's it. And that's important because we're talking about Georgia right now. I know they've been the press a lot for the last few months, but we're talking about boosting Georgia's health, increasing flu vaccine equity in our nation's public health capital. And so Dr. Michelle Cooke, a graduate of both Spelman University and Morehouse School of Medicine, will serve as our moderator. She is a board certified family physician and founder of Soul Direct Primary Care in East Point, Georgia. And among her many accolades, she was also recognized as a top doctor by Atlanta Magazine. And so I'm going to go ahead and let people that are more well versed in this topic than I go ahead and lead this webinar, and I'm going to turn it over to you, Dr. Cooke.
Thank you. Thank you, Brandon, for the introduction. I really appreciate that. Yes, I'm Dr. Michelle Cooke. I'm here in East Point, Georgia, which is pretty much in the Atlanta proper area, right in the metro Atlanta area. I serve a community that has been historically underserved. We have a huge primary care shortage here, which has really impacted access to things like the flu vaccine. In 2022, my area actually lost 2 hospitals, so we're really behind the 8 ball with being able to serve the community. So this work is very integral to what I do for the community. I'm really excited to moderate today's conversation about boosting Georgia's health. I've been a member of Georgia, a citizen of Georgia for more than 20 years now, even though I'm only 24 years old. But I've been in Georgia for a long time now, so it's my new home, and I love being here. But one of the challenges is that Georgia ranks so low on so many important public health outcomes, and flu vaccination uptake is one of them. So being able to discuss this today is so critical for protecting the citizens of Georgia. And so I'd like to show this slide. Dr. Hall has put this up for us. It talks about the flu vaccination rates. And this data was taken from Medicare claims data, meaning that if someone with Medicare goes to get a vaccine, we're able to record that and we can see who got their flu shots. So if you look on the left-hand side, it looks almost like a Georgia fall, right, with all the colors everywhere. The areas that are the deepest red have the highest uptake. What you'll notice is that you'll see the highest uptake noted around the metro areas or the urban areas. So you see Atlanta lit up, you'll see Albany lit up, you'll see Savannah, Macon. So those areas are doing a little bit better than the rest of the state where it's more rural. Now, the side that I think is particularly disappointing is the slide on the right, which is showing Black beneficiaries. So we're seeing much less uptake of the flu vaccine amongst Black participants. So only 34% of Georgian beneficiaries are getting the flu vaccine, and about half of that are the Black beneficiaries. So this shows where Georgia ranks nationwide. So unfortunately, we're at the bottom percentage, 38% and the 10th worst in the country. So we have a lot of work to do to improve that. I would love to see Georgia much higher, and this conversation is going to help take us towards that. Next slide. So again, we're going to get ready for our conversation. I have an amazing team, our Georgia-based team here who works in public health here in Georgia that I'd like to introduce. Next is Dr. Brianna Lathrop. She is a doctor of nurse practitioner, and she works at the Good Samaritan Health Center, and she's been a great advocate for flu and with the community that she serves, especially those who are uninsured or underinsured. Dr. Jeff Stone is a close friend and mentor of mine, and he is the senior VP of the Southeast Primary Care Partners. They have practices all over the state of Georgia, and he both still practices medicine, but he also administrates and helps to manage all the physicians and their team here in Georgia. He has a lot of insight on this. He's also past president of the Georgia Academy of Family Physicians. We also have Dr. Daniel Simmons here, who has a laundry list of all the accomplishments he's done in the public health space, including being an author of the American Disabilities Act, which I think is incredible. Dr. Simmons is coming to us from South Georgia, so he's in the Albany area where he's participated in many initiatives to help increase flu. I love having him on board because this is often a topic that we talk about from the medical side, like from practitioners like myself and Dr. Stone and Dr. Lathrop. But there's a huge partnership we have with community members, especially those who are part of the churches of our community. Finally, we have a special guest, Dr. Peter Alate. Dr. Alate is part of Dr. Jeff Stone's group, the Southeast Primary Care Group, and he is in Macon, Georgia. He's the lead physician of their practice in Macon, Georgia. And they have done some incredible work with being able to increase the percentage of Black patients who receive the flu vaccine. So he's here to share his secrets about how they make it work in Macon, Georgia, and what are the strategies that we go through. So without further ado, we're going to get started with the webinar. What I will tell you is that we have some questions that we want to start answering that I'm going to throw out to our team to answer about how they're addressing the flu vaccine shortages here in Georgia, or the lack of uptake of flu vaccine. But if you have any questions, feel free to put them in the comment in the Q&A, and we'll get through that. And you can also direct it to the group, or if you want to direct it to a certain panelist, be welcome to do that. So welcome everybody again. What I will say is our first question, and I think this is just a general question, but why is getting the flu shot important? What is the significance and meaning of getting flu shot? And anyone can take the floor for that.
I'll step up. Dr. Cooke, thank you very much for the introductions. You know, my particular organization, but most organizations are out to improve the quality of care in their community. But when it comes to, I'll talk about some of the money part of this, and that may sound very cold, but it's often referred to as the total cost of care or the medical loss ratio. If you're an insurance company, you don't want to spend as much as you need to make us all well. So again, sounding fairly abstract, a little bit 10,000 foot-ish, but one of the most cost-effective ways to reduce spending in healthcare is to keep people out of the hospital. And the best way to do that in a very relatively low-cost area is with vaccines. And that's the bottom line when we're looking for things that are monetary, to say nothing of absence from work or being at work and just not being as productive as you would have been. I could go on, but that's where I would start. This is important for keeping people healthy, out of the hospital, out of the grave.
Agreed. Thank you, Dr. Stone. Any other input on the importance of flu vaccine?
I'll add that in conversations with patients, I often talk about why flu vaccine matters not just for them, but for their community. So sometimes someone might not personally feel inclined, or they might not have experienced flu or feel at risk, but everyone has someone they love that's at higher risk. And so we talk about how getting the flu shot can also help prevent influenza from coming into your family and hurting someone that is more vulnerable, or someone in your workplace if you go to work sick. And also stressing too that flu really slows you down. It can be a week out of work. It can disrupt family responsibilities, caregiving responsibilities. And so helping people take a look at that larger picture of how, even if it feels difficult to imagine dying of the flu or even being hospitalized from the flu, that the day-to-day inconvenience and also the pain of potentially hurting someone you care about is another reason to think about contributing to declining rates of influenza in our communities.
Absolutely. I couldn't agree more with that. I think that's one of the things I talk about with my patients at times, who, if you feel otherwise young and healthy, they think they're going to take their chances with the flu. But some of my patients touch very vulnerable populations. So they take care of their elderly mother, or I had one patient who was very flu hesitant. She owned a daycare. So you have this whole daycare of these young children. And I was like, even just for their protection, getting your flu shot is so important. So protecting not only yourself, but the members of your community. You never want to feel like you may have been the vector that exposed somebody if you could have done something about it. So I think that's a really powerful message.
Yes.
So next question, I think the way you all explained it, it feels like a no-brainer to get your flu shot. You know, less morbidity, less hospitalization. You can stay at work longer. You're not hurting members of your community. With all of these compelling reasons, can you talk to about why we have such low rates, or what are the barriers? Where have we failed in getting the message out, or what is the challenge that you think our patients are facing and the citizens of Georgia are facing with not getting their flu shots, despite all the evidence that supports how valuable it is?
I will start with that one. I've got a long list, but I will give you two. One is the messaging. Mm-hmm. When I watch television, when I look at ads about getting the flu shot, the vast majority of them look like people who don't look like me. Mm-hmm. They are people, just generic people that have no influence over me and the people that I serve. And just based on who they are, inherently, I don't trust them. Even if Walgreens or CVS or any pharmacy, it's their commercial. I'm not hearing that. And so the messaging has to change. It has to be more diverse. It has to be more inclusive. It has to be localized. Use people in the local market to try and encourage people to get the vaccines. Because when I hear them, I think they're talking about somebody else. They're not talking about me. And then the second thing I would say is access. When you go back to the chart that you put up, and you see those zip codes where the rates are low, and what you will also see in those zip codes, there is no pharmacy, there is no physician office, and so people in those zip codes don't have access. And getting where I live, some people would have to drive 20 miles to go to a physician's office or a drugstore. And I'm old school, so I call them drugstores to get a shot. And again, the people in that community, the voices that are messaging the need for the shots, they're not hearing those voices. And so we've got to create more access. And part of what we do, and we can talk about that later, but part of our role is to add access points and improve the trust factor for the vaccines.
Thank you, Pastor.
Yeah. I'd also like to make a couple of points on some of the reasons that I have found in my practice why some of the patients do refuse the vaccination. One of the key ones I have found sometimes is the healthcare personnel, because they will sometimes ask the healthcare personnel, have you had the flu shot yourself? And if the one says, no, I didn't take it. So you did not take the flu shot. So why are you asking me to take the flu shot? So then right away, we have a problem over there. So we start off by making sure that the healthcare personnel have a good understanding to be able to explain why they should take the flu shot and they themselves should take it. And then, like you said, the distrust regarding the vaccinations, that people don't trust. And some will say, I'm very fearful of needles and I just don't want to be jabbed, so they don't want it at all. And then there's those who believe that, why take the flu shot? And they will come in, why take the flu shot when I can let my body fight the flu to build that natural immunity instead of trying to get the immunity through and what they call, the word they use is artificial means, that this is not a true, and they want to try to build their own natural immunity instead of through immunity through vaccination. And a few will come in, which is now actually getting less, and say, oh, I can't take the flu shot because I have egg allergies. So because I have a problem and I can't, and there's a part of the medication, the vaccine involves being prepared in eggs, therefore they don't want to take the vaccine. But again, this is not really a good reason. And then the big one is, I guess sometimes is for religious reasons. They'll tell me, no, I don't want the vaccine because of my faith and I do not believe in it.
Thank you, Dr. Alate. I think that's really powerful, acknowledging faith-based issues. And I also like what you said about if they hear that there's a healthcare worker who hasn't received it, it kind of reaffirms the system of mistrust. So the education starts not only with ourselves, but even with the teams that we work with. I want to highlight that David in the comments put that sometimes people don't believe us. They had a flu shot and got a flu-like illness, so they're not sure if it works or they have a bad experience. And that is a great point to bring up. So I want to share a story that I do with my patients, because if you don't acknowledge what people experience, you're going to create distrust. So I love to give anticipatory guidance, because I hear people will tell me, oh, Dr. Cooke, I got the flu shot last year and it gave me the flu, or my friend got it and it gave them the flu. And what I'll tell them is that the flu shot cannot give you the flu, but sometimes you can feel like you got sick. That's a very real thing. So I try to prepare people for that. That can seem kind of scary, but the story I tell them is like the flu shot is training your body to fight the flu. And if I told you I wanted you to train for a 5K race and you go outside and you run 5 miles or run 3.5 miles, how are you going to feel? So you're going to feel a little tired, a little out of breath, like you're just going to feel like you went through work. Well, when we train your immune system to fight the flu, it's going to pretend like it's fighting the flu. So sometimes you can get some muscle aches. You can feel a little fatigued. And if that happens, I'm really excited because that means that your body is learning how to fight the flu. I actually feel really good when people tell me that they've had that response to the flu shot, because that means you're very prepared if the flu comes around. So when you train for it, you might feel like you trained for something. And that story resonates with some of my patients and gets them prepared. So if they don't have that reaction, like they're okay, they're like, okay, it didn't bother me. But if they did, they kind of knew what to expect and knew why it happened. But you can certainly promote mistrust if you talk it up and say it's going to prevent flu. I give this patient a shot and they feel horrible. So you have to really acknowledge the patient experience there and get them prepared for what they're going to go through or what they may go through.
Right.
Excellent question. Okay, so our next question here is, Pastor Simmons, you talked about this with trust, access, and convenience, that those seem to be some of the three biggest issues that are stopping us from getting the flu shot. And I would like to ask all of you, with the populations that you work with, how have you been able to get past those barriers to improve trust, improve access, and improve convenience?
I'll let someone else go first and I'll be second.
I think Dr. Alate has a great story about that, right? Because your rates at your office have really outpaced anything else we've seen in Georgia. So if you'd be willing to speak to what you're doing, and that would be wonderful.
Can I tell a story first so that I can introduce Dr. Alate? People don't really know who he is, but he's very important to the Southeast Primary Care Partners that has 45 clinics in Georgia. And Peter, I hope you can remain somewhat humble before I tip my hat toward this. What we did last year after joining the DRIVE program that was sponsored by the NMQF, we worked in collaboration to create an awareness campaign with the Georgia DRIVE by getting and recruiting office champions. And that was from most of our 45 clinics. We did that in cooperation with our operations manager. And we used billing and inventory data to count flu vaccines administered. We even had a fairly late start in early November, but that still allowed for a couple of webinars to elucidate the racial disparities in our state and then emphasize the overall need for flu and adult vaccines since 2020. I mean, there were buttons and posters and scripting instructions and education to insurance workarounds like the Transact RX billing vendor to ensure affordability and reimbursement. And we kept in touch with sharing of the PowerPoint slides and the things that were provided by NMQF as well, too. And we instituted something else, an incentive, a monetary prize, if you will, to the office that could increase their rates of the most. And that was established immediately after our first educational webinar, because it wouldn't be fair to take a big practice and compare it with a small practice. And Dr. Alate's practice is somewhere in the middle there. Well, I hypothesized that our best performances would be realized in the traditional suburban mixed race practices. And I was wrong. and Peter's practice proved us wrong. Almost all of the clinics with champions did see an increase in the flu shot production, but the winning office in an historically Black practice in West Macon increased their flu vaccine production by over 230%. There you go, Peter. This is it. I have my own theories, but Peter, I think Dr. Cooke started it. What's your secret sauce? How do you win the trust? How do you provide the access? What do you do that just did better than everybody else in all 45 clinics?
Oh, thank you, Jeff. Thanks for this introduction. Pretty much, we did some very basic things in putting it together. The very first thing was for me to come out and say, who is going to lead this flu program to make it successful? So I put myself as the champion, that I'm going to be the lead to start the program and to get it going. So once that decision was made, I then got all my physicians, my other physician and my two mid-level providers on board and said, we are going to try to vaccinate as many people as we can. So we informed all the staff, got everybody on board, and then came out with our own internal standing orders, which we put into place, that each one who comes in, you have to pull out their GRITs, which is the Georgia Registry of Immunization, to look at and find out if they've had a flu shot or if they need any vaccines apart from the flu shot. Once we identify that and the patient comes in, whoever gets the patient just tells the patient, you had your last flu shot in 2022, so you are going to get your flu shot today. So we do not even ask the question, do you want a flu shot? Because that gives the patient a chance to come out and say no. So now that led to quite a number of the patients accepting the vaccine even before I walked into the room. And those that did not, then I have now the chance to talk to them and explain to them that I personally have taken the flu shot. And therefore, I think that it's very important, and the importance of taking the shot and explaining to them how it impacts, apart from helping themselves economically, their health-wise, and the people in their home. Because if you imagine you getting the flu shot, you'll be out for a week or week and a half, it hits your paycheck, it hits all the other things that is going to happen. So we send out regular reminders also. We had on posters all over the office. We are offering the flu shot. Now, the biggest one that I personally found of all the things was the ability to offer multiple vaccinations. So the key thing was, we're not really trying to drive an increase only in the flu vaccination, but to increase vaccination across the board. So what then happens is that the patient comes in, starts talking to me. I say, okay, from the greets, we see you haven't had your pneumonia shot. Okay, so we're going to give you your pneumonia shot. So if you're going to receive the pneumonia shot, why don't you go ahead and take the flu with it? Because the two will complement each other. Why don't you take the RSV and the flu shot together? So will that work? Yes, it's going to give you a better, because you're covering more infections and protecting yourself against more infections. And we found that but doing this, a number of cases, patients that were vaccinating for flu, for RSV, for shingles, everything increased across the board. So it was not an increase specifically only for flu, but everything went up big time. Now we also we have quite a number of pastors who are members of our, our patients in this practice. We spoke to them, I called them, I asked them, please tell your patients, those who are patients here, to come in and take the vaccinations. So quite a number the pastor said, we should come in and get our vaccine because you've talked to them, he's taking theirs. So the pastors were very helpful in making things, happen. And we just kept on with it, and slowly, it got better and better. It got easier for the patients and everything. And this year, it's actually going very well, quite well. So, for instance, today, or because of this meeting, I cut a short day. I did 10 patients, and of the 10 patients I saw, 6 people took the flu shot, So it's some days it's better, but we are getting very good numbers of patients taking the shot.
Amazing. Thank you, Dr. Alate.
Yeah.
I think setting the culture in the office is so important, and it sounds like you established that really well. You kind of assumed consent, to get them to opt in before they opt out, which I think is also a great strategy. Another thing that you mentioned is you mentioned GRITS a few times. So for those of you who don't know, GRITS is the Georgia Registry of Immunization. I'm going to forget the rest of it, but it's our state registry for immunizations, where you can look up what vaccines people who have had, and if ever you give a vaccine in Georgia, you update that registry. So it's very helpful in tracking what's going on with vaccines. I love it. It's a really powerful tool. For you, it helped identify people who would benefit from vaccines, not just their flu shot, but other vaccines they may be due for. And I almost wish it was national, now that we have people that live in different places and travel, that we had a national registry of vaccinations. So if people get vaccines out of state, we could hear about it. That's very helpful. I want to jump over to the Q&A. There's been some questions that are posed. There's one I'm going to go back to, but David Mann put a question in the Q&A section that asked specifically what was the absolute increase in vaccination rate, not just the relative increase. If you all have the answer to that, if you could type the answer. I'm not sure if you're able to type that answer, but if you can type the answer to me, that would be wonderful.
I can type the answer or just answer. I would say typically we've been doing close to about 55-60% of our patients been taking the vaccine. This time we went up to about 71, 72. So if you take that, that would be like 1 out of 6. So that would be an increase of maybe about 15, 16, 17%. Because we're already doing very high numbers, close to over 60%. So if we went going from 60% to about 70, 75%, we over 15, 20%.
Wonderful. We have another question that said that some people want the flu shot, but they cannot afford it. How can we help individuals afford the actual vaccine? So I'll throw that to the panelists if you have suggestions there.
I'll step up for that one too, because I just put it in the typed and chat section. You heard me mention this thing called Transact RX. It's a third-party billing vendor that will accept whatever you have. That is to say, your situation as a Medicare patient, and will get the reimbursement from your company itself. So there's no out-of-pocket expense for you. It's a brief online application. It takes less than a minute or two to complete the demographics and get that in there. So that works for that population. There are obviously other folks that are indigent without insurance whatsoever. And that was one of the reasons I called Robin Coffey to be a part of this. She may be a part of our listening audience. And she quickly educated me to something called the 317 program. Some health departments or counties are bigger than others, but they basically offer a lot of this for, once again, a very small application. You don't have to worry about being a citizen per se. You just have to fill out that sheet of paper and you'll get your flu shot for free. So that's one way to do it. But again, these folks have to get to where they can get it too. So access to care, social determinants of health are still a big issue, even in my practice, which has a very large Hispanic practice. But those are two ways to get the job done. And I'm looking for others if they're out there on our panel.
Yeah. Go ahead. I see you getting ready to speak. Go ahead and I'll follow you.
All right. My patient population is about 87% uninsured. So that is primarily when we're talking about who we're seeing as well as who we're vaccinating. This is our main issue. I always think of patients when it comes to flu vaccines in sort of three groups. There are folks that really believe strongly and want that vaccine every year, and they will do whatever it takes to find a way to get it. And then there's a group of folks that they don't do any vaccines, or they're very hesitant, or for whatever reason, they do not want the vaccine. But most people fall in this middle, which is they are open to the flu vaccine, but they are unable to make a significant financial contribution to it. They cannot drive across town. They cannot spend a day off work to go to a health department. And for us, that is the group that we start with, to say if there are people that would give us a yes, if we could make it accessible, then that's what we need to do first. And so our clinic uses two main approaches to have flu vaccines in stock so that we can give them at point of care to our uninsured patients. First, we are participants in Georgia's adult vaccine program. So this allows us, similar to any clinics that might participate in the Vaccine for Children's program, we are able to put in regular orders for adult vaccines and receive shipments that come through the health department, are paid for, and arrive at our clinic to be able to give those vaccines. We receive them for free and we give them for free. So we don't do any charging for the supplies at the time of our team. We also do direct purchase from companies, bet them against one another to get the best price we can. And we make up that difference with what we call private stock. What that allows us to do is tell our staff that there is a vaccine for every single person that walks through this door that will say yes. And what we find is that because they are coming to a place where they already have trust for their primary care, they've made the commitment to come to a visit, that making it possible for people to say yes in that moment is what has made the biggest impact in our ability to vaccinate our population. I always add this on talks like this because I think there's an advocacy component here that, community clinics know their patients. They have built trust, they have built relationships, and can get vaccines rates up because of that trust and that relationship. which means that we just need continued investment to say that let's solve the access issue so that there aren't any clinics that would be advocating, would be having these conversations, and simply don't have vaccines to put in arms. And we can tell that story to anyone that will listen, from the manufacturers to the health departments to our government representatives, that the better we can do at making it easier for community health centers, private clinics, all of us, FQHCs alike, to have stock both for insured and uninsured patients readily available, will make a massive difference in how we can increase vaccination rates.
And let me just add that beginning with Brother Terry, everything that has been said, I think is right on point in terms of increasing the rates and access. And what I will say is, from experience, as we talk, the only thing that needed to be added to the conversation is to view the faith-based community as a full-fledged partner. And Terry said he talked to the pastors and they got people involved. But even beyond that, just making us a larger part. And so, for example, I mentioned earlier, these healthcare deserts, you don't have physicians, you don't have pharmacists, and then people got to drive in. See, we eliminate that problem, because in every one of those communities, I promise you there's a church. Mm-hmm. And so what we do, Mount Zion is one church, but we've created a coalition of churches across this region. And so what we do on a Saturday or a Sunday is bring the clinic to the church. That church is transformed into a clinic. There's physicians there, there are nurses there, and depending upon what we're doing that day. And they're not just coming to get a shot. They're coming to an event. And based on the church you go to, it'll be different, but it looks like this. When you pull up, there's music. You can hear it. You will see some men from the church who volunteer. There are grills going. We are cooking. They're going to eat. There's a truck over here with vegetables on it, and produce, and fruit, and milk, and meat. And after you get your vaccine, you are going by that station. There are barbers in there. And if you're a man and need a haircut, you're going to get a haircut that don't cost you a dime. And these fresh fruits and vegetables provided by local farmers don't cost you a dime either. And what happens is, prior to the event, the pastors have been pushing this. We have trained champions in all of our churches who are basically health navigators without the title, who are working the community, working the church. And again, these trusted voices and people and the physicians and the nurses and the people we bring in, we've introduced them to our congregation in various ways so they know them. And so the people come. And we do the multiple vaccines on some of these sites, and some of them single point. But the other part is this. Let's see. Miss Latrip, did I say it right? She, she talked about how there are three groups of people. And so this is part of the group. She talked about what we see. There are some people who are excited. And there are some people, just given the right information from the right people, they'll do it. But there's some other people who need information and incentive. Mm-hmm. And so what we offer is the information and the incentive. And so we actually give people ranging from $25 to $100 for a vaccine. And so, for example, like recently we had one on that particular day, we were doing flu shots and COVID shots. COVID shots were $100. And then the flu shots were $25. And for some people, that $25, that $100, that's why they came. And in fact, if you run out, and we often run out of the incentive because that's limited, they say, well, I'll come back the next time that you have the incentive. And so when you bring us to the table, you really get the opportunity to have a clinic in every community where people can walk, where people can come and socialize and share stories, and then that trust level begin to build around what's going on, and we can help. And let me just say this and I'll be through. But the biggest barrier for us wanting to do this is healthcare providers not wanting to partner with us. Local health departments, it's a fight. It's a fight. Other healthcare providers, it's a fight. Now, our church has we've been in healthcare since 2008. We also have a health clinic where we provide services to people without cost at all. They don't need insurance. But again, we're in the community providing the services. And so people recognize the church, not just for what we call the spiritual value, but we're a healthcare provider too. And we got a number of programs. And every single partner we've had from the healthcare profession says that their numbers jump out of the roof once they partner with us. And they don't know why it took them so long.
Thank you, Pastor Simmons. That's amazing. And I think you and Dr. Lathrop highlight just the importance of working with the communities. You talked about how the community health centers already have that trust and the churches have that trust. So I think it's a huge untapped resource. Yeah. I do want to throw a question back out to you when you talk about the incentive, the $100 for a COVID shot, $25 for a flu shot. Where does that funding come from?
Two places. We've actually been able to get grants through the COVID funding for that. And then we have pharmaceutical companies that partner with us. And one in particular, they don't even make flu vaccines, but in terms of just improving the overall quality of health for people that are interested in that. And so they provide the incentives. And then the partner churches, we all pay into the coalition X number of dollars per year, and we can use that funding whatever we want to. And sometimes it's for the incentives. But there's a lot of grant money out there where you can actually get people paid. And we take care of doing all the paperwork to get the shots paid for. So whether it's through the Department of Public Health or through some pharmacy that we're using or through a physician, we manage all of that. So when the patient comes, they don't have to worry about paperwork. They don't have to worry about any of that. We manage all of that.
Amazing. That's incredible use of the community resources. I wanted to go back to, I saw a question, looked like it appeared that it may have been answered, but I thought it was an important question to talk about, where an attendee mentioned, how do you spend time, or how do you find the time to talk to patients and people who are interested in flu shots when there's so little time in healthcare to discuss these things? I'd love to know your strategies and tactics.
One of the things that I've trained my staff to do, and it's inevitable anyway, is that they know that I get a pretty good take when I'm given enough time to do it. So one of the scripts that my nurse uses before bringing the patient into the room is, hey, which arm do you want me to put the shot in? Like Dr. Alate, not do you want the shot, but which arm do you want to put the shot in? And if they give some hesitation, she has a second line, which is, I know you, you know me, you know Dr. Stone. By the time he leaves this room, you're going to get a shot anyway. He's going to talk you into it. So why not just get it now and get it over with? And I will tell you that works about 50% of the time. Again, it's scripting, it's trust, it's knowing the patient for a long time. But it's not whether you want the shot, but how are you going to get it? And we know we're going to talk you into it. So when she does that, I don't have to spend all that time on it. But there are times when I have to spend that time, and it's a resource that's definitely limited. Great question.
Yeah, I was going to add on to a little bit to that. What we have done is that we also have posters all over the place, so that right away they already know that is there, and then we have some printouts about the vaccine and the side effects. So whilst the patient is sitting there, they have the opportunity to actually be reading that. Then I also have all the nurses and the medical assistants also talking to them and explaining things. So by the time I get there, if they have any extra questions that have not actually been answered by the other employees, then I take those on. So that helps to save time. Instead of me doing all the talking, I solicit the help of the the rest of the office to help with that.
Yeah, I agree with Dr. Alate's comment there about the importance of just the team-based approach to flu vaccination. I could not get patients vaccinated if my team wasn't also doing just as much work. I always think back, we did a study a few years ago, specifically around a clinic we run here that's an outreach program for people experiencing homelessness. And we had a really high follow-up rate. I promise this relates to vaccines. We'll get there. But we are really interested to know, why do people come back? And during this study, you know, I had thoughts about like, well, it's probably because the care has no charge, or because we dispense the medicine here on site with no charge. I had, you know, we serve lunch. Like, we have all these reasons, right? Do you know what the number one reason was? It was that they identified someone on staff, not necessarily their provider, but someone that they would consider a friend or a family member. And so when we think about anything that requires change, whether it's the idea of accepting a flu shot for the first time or first time in several years, or whether it was when COVID vaccines appeared and there was a lot of fear and question, that I always think that what makes people trust us enough to come back is a person here. And that person might not be their healthcare provider. It might not be me. It might be my medical assistant. It might be the person at the door that greets them. So when I think about flu season, I start by, we partner with a local pharmacy that brings a flu shot in for all of our staff members. And we all get vaccinated together the same day. We talk about why we get vaccinated. We share stories. We hand out our buttons that say, like, I got the flu vaccine, how about you? And that's where the conversation starts, like that staff feel like, I care as much that you get vaccinated and you're protected this season than I do any one of my patients. Because like, it starts with us, and we're family here, and we got to protect each other. And when we do that well, that's how we protect our patients. So it means that sometimes the first person that asks, as in many clinics, that first person is the medical assistant, and she's wearing her button, and she and my patient go way back, and they're like checking in on grandkids. And then she's like, oh, see my button? Can I get your flu shot today? And I think that that's often a segue for me, that sometimes I spend no time in a visit. Like, that conversation's been done. They've maybe even done some question and answer together. And it leaves me more space in my schedule for the times that a longer conversation is needed. Instead of it being every patient, it's a couple patients.
Absolutely. I think the relationships matter so much. That building that trust goes so far. The other thing I like is what Dr. Simmons mentioned, making an event out of it. We talk about, if you can create a positive experience. We talked about the music playing, there's food there, like people start to look forward to that flu shot event, right? Like, I want to go next year because there was such great food. I left with groceries and I had a good time. And so you take it so much away from the flu shot, but you make it about this community initiative. And I'll say, even as a healthcare professional, when the COVID vaccines came out, even though I was very excited to get my COVID shot, I certainly had some hesitation. And I remember at our hospital, I actually think Dr. Stone was there with me that day. We had a mass event. We were all together in a room. We were going to get the COVID shots together, and being in that group and making it a safe space was really motivating for me, to let me know that I was going to be okay. A lot of our patients get their shots in the exam rooms, but that can be a lonely place sometimes. You know, you talk about this shot and they leave the room and you're by yourself to think about you're going to get jabbed or whatever it's going to be. Then they come back in. But if everybody's doing it together and there's a celebratory element to it, it can make it a much more positive experience, and one that you're willing to engage in again and again. So creating that experience for the community and for the patients, I think is a great strategy. We had some other questions pop up. One was specifically for Dr. Peter Alate about, how do you deal with patients who are hesitant to vaccine reactogenicity, and what important messages do you incorporate when making those recommendations? So I don't know if you have any thoughts to that, Dr. Peter.
Yes, I do. Actually, it's a very good question, because I do have quite a number of patients who will come in who are not really like refusing the vaccine, but they are very, just like she said, hesitant to take the vaccine because they're worried about what they know. They are the group that I spend the most time on or with, because they are the ones that I have to go through the process of explaining to them what the vaccine stands for, what the importance of the vaccine, discuss the make of the vaccine, go over the side effects of the vaccine, the possible things that can happen, to let them feel comfortable, because these ones usually may have had one vaccine in the past, and therefore they are hesitant to try to take a vaccine a second time. So therefore, with them, I just go through, explain the whole thing to build that trust, to let them know that because you took a flu shot in the past and the flu shot did this to you, and you said you came down with the flu a week later, does not mean that you're going to have the same thing that will happen to you the second time. So there is a matter of trying to build a trust, and then for me then to try to lay out the clear benefits as against the risk of taking the vaccine, to let them have a clear picture that this vaccine is going to be beneficial and in the long run is going to help them more than do harm to them. Now, if there are other options that I have, if the vaccine comes in other forms, then I can choose that opportunity to try to present it. So let's say the person comes and says, okay, I'm scared of, I would like the shot, but I'm hesitant because I do not like being jabbed with a needle. Then I can say, do you want to maybe get the flu vaccine, get a nasal form of it instead of taking the shot, which will still give you what you want, to have the distance. Do you want it in an aerosol form, in any other form, if it's available, and then present it in a different way, and then see how it goes. And I'll say more than about 60, 70% of the time, the hesitant ones come around. And then when they come back, I'll give them the shot. I'll say, I'm giving you the shot. Today you've accepted, but I'll call you back in a week's time or 2 weeks to follow up to see whether you had any reaction to the vaccine. And then usually when I call back, which I don't personally sometimes don't, if I do, fine. If not, give the job to one of my medical assistants, call this patient back next week and find out, are they okay from the vaccine? And so, well, they did fine. And so subsequently on the next visit, I'll say, I heard you did fine with the vaccine. So let's go from there.
Absolutely. Thank you, Dr. Alate. I think that follow-up, again, it reinforces the trust that you build with the patients. There's another question specifically for Pastor Simmons, but anyone else who works with grants and pharma, if you could answer this too, about how else do you raise funds to get support from the medical community, and are the funds sufficient to cater to the growing needs? So I'm going to put that out there, but even before you say that, I want to say that you mentioned how sometimes your incentives would run out. So it sounds like there is still a greater need for it to have some of those incentives that are available. But Dr. Jeff Stone started this by saying, or really making a financial case for the flu shot. $125 is a lot for people right now, especially just with where the economy is for Main Street. And if we think about how much we save, if we pay people to get the flu shot in their hospitalization, in their lost wages from productivity, it's almost a no-brainer. So it seems like what we can benefit in the savings is already there, but it's very hard to prove prevention. It's hard to prove what didn't happen, but I'd love to know if you have other suggestions about where grants and pharma, if it's enough, and how much more they can do to support us. Oh, Dr. Simmons, you are on mute if you're speaking.
It is not enough. Rarely do we have enough. But what we do is relationships, the most powerful thing in the world. And so what ends up happening is that because of the relationships we have, for example, our local healthcare system will provide whatever staff we need, nurses, physicians, lab testing, whatever we need to us at no cost. So we get their nurses to come work on a Saturday or a Sunday, and they pay them, we don't. If we run out of something and we need it, we can get a local provider in most cases. Like, for example, there's a local pharmacy called You Save It. It's a locally owned chain. The people are from the city, and they'll step up and help. Again, the hospital system, through the clinic that we have a lot of volunteer physicians, and so through their offices, they will provide. And I will go ahead and just say Amgen and Takeda have been very supportive in the work that we're doing, because what we do is so like the primary work that Takeda sponsors is around prostate cancer and gut health. But they allow us to pile vaccines on top of it. And so to use some of their money to help us to do that. We've got the people. And then your school, Morehouse School of Medicine, is off the chain. We love them. And it's been a mutually beneficial thing. So we, so they are a partner, provide funding. And recently we've started doing some clinical trials. And I don't know if you know Dr. Killer or Brian Rivers. And I'm going to brag for a minute. Ask them the number of participants in the clinical trials by African-American men exceeds anything that you all, and I will submit anybody's doing. We'll get 100 men in there, tell them about the program. 76 of them commit to the clinical trial.
Wow.
And we have these groups coming, and we do them about every month. And so we are making Morehouse real happy right now. Yeah. And so, no, to say that the answer, we need more money. So anybody that know where some money is, call us, and we'll be glad to do what we need to do to get it.
Absolutely. Thank you, Pastor. And I think I'm very proud to be a graduate of Morehouse School of Medicine. My own practice is just probably about 2 miles up the street from the actual campus, so I'm not very far away. And I think it highlights the point of when you can go to or connect with a community that looks like you and reflects you. You started this conversation by saying a lot of the flu materials out there don't look like they're speaking to you or that they reflect you. But when you can get it right in the community from providers that look like you, from a space that you're familiar with, it makes a big difference. I wish this weren't the truth, but it is true. We have a lot of data that backs up that Black patients who get care from Black providers do better. They just have better outcomes. So it doesn't mean that you can't give culturally competent care, but if there's a win-win with connecting with them with providers that look like them, it makes a big difference. And I think that's how we get that 50% flu rate from the Black patients up to matching everyone else, then hopefully go beyond, because we still have so much further to go to catch up to the rest of the nation. So impressive work with you and with my medical school.
Yes.
David Mann mentioned as we were talking about the pricing or savings, that the problem is always getting people reaping the savings to be invested in the work that produces the savings. And that's always a challenge. I don't know if anyone has anything to speak to towards that.
Yeah, not directly towards that, because I agree that is always a problem. But I mean, certainly a second on Dr. Simmons, that the money is never enough. Our organization raises 80% of our budget each year. And so I feel that. One thing that we've had a lot of success, though, is really thinking about our programs. For example, flu vaccination, saying like, what is the big picture cost of that? So there's like the provider time, the medical assistant time, cost if we go out and we do outreach events and partnerships. And then there's the cost of the vaccine itself. And it means that when we have FaceTime with potential funders, whether those are individuals or a group working on vaccine hesitancy, for example, we have an idea of what does it cost us to do the work we need to do. Now, when we get in front of that group, sometimes they say, oh, we would love to support incentives or posters or stickers, but we don't fund staff time. Or a group that says, we'll fund staff time to talk about vaccine hesitancy, but you can't use our money to purchase vaccines. And the nice thing is, because we have this big picture of what it costs, we say, okay, great. So if I can get staff coverage and this covered, then I can put other operational resources into purchasing the vaccine so that I can make it free for every single patient. So I think that is also a strategy if you're working with like a community-based organization, or you're with an organization where you're fundraising a lot of it, is to really make sure you're crediting like what is the true cost and what are all the ways that feed into that, so that when opportunities come out, you can parcel out what matches this funder's interest. And then there's the piece left that, if you have kind of a more unrestricted or general operating, you can shift more resources towards the place that is more likely to fall short.
Excellent. I've run into the same challenges too with our practice. We were trying to do a flu drive, and there was a lot of restrictions about where the money could be used. And so you do have to get very creative in those spaces. So those tips are really helpful. Let's see. I think we had another question that came in the Q&A that said, on the issue of hesitation to take shots, are we doing enough to educate folks on the need to be represented in research in order to increase the diversity in clinical trials and increase trust? I think that's another good question for you, Dr. Simmons.
No, yeah, we are not. And this is just me now. I'm not speaking on behalf of anybody else. And I think, unfortunately, it's intentional. if you know what it takes to increase the participation of a certain group of people in clinical trials and you refuse to do it, then it says to me, it's intentional. All you got to do is change what you're doing, and you'll get the increase in participation. And so we got to keep saying it. We got to say it loud, and we got to just make it happen. Because the medicines that we are producing, if we've not been a part of those clinical trials, you really, really don't know what the outcome is going to be. And I'm smiling because I actually participated in a clinical trial. And I was the only African-American man in the trial. And the physicians, and we would have this conversation, and they come back and say, well, you're the only person respond like this. And I said, that's because you got all them white people over there. You ain't got no black people. You gotta get somebody in there that look like me. We are not all the same, as much as we want to say that. We are not all the same. We're different. And so you gotta, well, you don't respond, and I'm different. And you have to acknowledge that. And if you're gonna get this medicine and treat people who look like me, you gotta get more people who look like me in it. And the interesting thing about the clinical trial, now the people at the place are not the people that invited me and got me to be a part of it. It's a physician friend of mine who lives in another state who called them. And I'm talking about Georgia now, and had them to put me in it. They didn't want me in there. And I won't call the name, but yeah. So yeah, it's we've got to do more, and we've got to be intentional about it.
Thank you, Doctor. Well, we are rounding at time, and I want to just take this moment to thank all the panelists who joined us today to give your expertise on what you're doing to increase your vaccination rates here in Georgia. I think we've identified some key partners, including the Department of Public Health, pharma, grant funding that's been available that some of our participants have been able to leverage to be able to vaccinate their community. So I think we have a lot of partnerships that we need to further leverage in order to get this done. The next thing I'll say is that this webinar has been recorded, and I understand it will be made available on the NMQF YouTube page. So if you missed part of this, or if you want to come back to watch it again or share it with someone else, it will be available on the YouTube page. I will close out, but I will throw this back to Mr. Brandon Garrett if there's any closing remarks you have before we end the webinar today.
Oh, no, I just want to thank you guys for doing such a great job and our audience for participating. It will be, like you said, it will be on our YouTube page probably within the hour. Ashley's really quick on that. So if you want to reference somebody had a question or you want to get back to, you please reference it there. Also, does the panel, do you guys want to share can we share your maybe like a website or a contact information for you guys if possible?
Sure. Let's see.
All right. Well, we will do that as well. And I'll turn it, just thanks, Dr. Cooke and team for doing such a great job. We will see you next week. And remember to go and vote.
Oh, yeah.
This week.
Yeah, by Tuesday. Yes. Georgia, see, that's the only sticker I want to see. That's the only sticker. That's the only brand or logo I want to see from now until Tuesday.
Yeah, I got it.
All right. Thanks, folks. Have a good weekend.
All right, you too.